Hello and welcome to Excellence in Practice, Voices for Better Care, a podcast by the National Centre of Excellence in Intellectual Disability Health. Here we will be sharing real stories and advice from expert clinicians and people with lived experience on improving healthcare for people with intellectual disability. We hope you enjoy this episode. I'm Ricky Kremer and I am co-hosting with Raylene Griffiths.
The National Centre of Excellence in Intellectual Disability Health recognises and respects the traditional custodians of country across Australia. We acknowledge their deep and ongoing connection to land, waters and community and pay our respect to elders past and present.
This podcast includes discussions about the healthcare experiences of people with intellectual disability. Some stories may include mentions of trauma, medical mistreatment, or discrimination, and could be distressing for some listeners. If you are uncomfortable, please take a break or skip this episode. Thank you for joining us for this episode, where we will focus on the bias faced by people with intellectual disability in healthcare. Unfair attitudes or assumptions can influence how people are treated in healthcare. It can mean that people with intellectual disability sometimes get worse healthcare. Biases aren't always intentional, but they can have serious, even life-threatening consequences. It is important for healthcare professionals to be aware of these biases and learn how to make sure everyone is getting the right care. This episode is in two parts. In part one, we will be speaking to Dr. Jessica Smith, who is a member of the Centre's Council. She is also a rehabilitation physician and clinical lead researcher in models of care, supporting general health needs of adults with intellectual or developmental disabilities in the Southern Adelaide Local Health Network. In part two, we will be speaking to Rachel Browne, who will share the story of her son, Finlay Browne, who tragically passed away after not being able to get the care he needed in the healthcare system. Thank you, Jessica and Rachel, for joining us to talk about such an important topic. To our listeners, we hope you enjoy the episode and learn about how we can improve healthcare for people with intellectual disability. Hi, Jessica. Thank you for joining us today. Can you please start by telling us about yourself and your experience working with people with intellectual disability in healthcare?
Thanks, Ricky, and thank you for the opportunity to talk about this. So I'm a doctor and I've worked providing healthcare for people with intellectual disability for many years. I actually started 25 years ago working as a support worker in the community, and then my career went into medicine and I became a GP, so I was a general practitioner and started the private service in Adelaide, providing community care, being a local GP for people with all sorts of disabilities, but particularly those with intellectual disability who needed a different approach And in recent years, I have become a different type of doctor. Now I'm actually what they call a rehabilitation physician, and some people would say that I specialise in looking after people with disability. And I have a particular interest in looking after adults who have had an intellectual or developmental disability.
So based on your experience, how have you seen biases in healthcare impact people with intellectual disability?
It's a good question, Ricky, and I think there's lots of ways as a healthcare professional that I see this day in, day out for people with intellectual disability. And I know that because I almost have to fight the system at times to get access to sometimes the most basic healthcare for some of the people that I look after. I guess when thinking about some specific examples of bias, there are a few that come to mind for me, and some that I see really often, quite frequently, in the community. One, I think, is around complex communication needs. So people with intellectual disability often are assumed that because they have a different way of communicating, often health professionals think that they don't understand the information or the decision that needs to be made or thought about in terms of their health care. So that's really something that I see a lot of, and I don't think health professionals have had a lot of training in how we adjust our communication to ensure that we can be more inclusive in our approach to providing care. And sometimes I see a lot of bias and assumption around people's level of disability with this. So sometimes people assume that people have an intellectual disability if, for example, they're nonverbal or have an alternative way of communicating with people. So that makes, I think, decision-making really complicated. And that kind of leads into my second example of this around capacity to consent to treatment. So that's a really difficult situation that often is encountered in the healthcare setting. And I see a lot of bias and unconscious bias, I would say, in relation to that issue, where healthcare professionals sometimes assume that somebody doesn't have the capacity to make a decision or contribute to part of that decision-making process. And so you'll often see health professionals who are very time-pressured and will usually direct their questions to a support person or a caregiver who may actually be present with the person with an intellectual disability for the appointment. And I think that in itself is a bias that we see quite often in the community. I think the other one that I see most commonly is people who have, for example, who are minimally verbal or non-verbal, who display a change in behaviour. And a change in behaviour, or sometimes people would call that a responsive behaviour, is often thought to be a mental health condition. And so I frequently see these referrals for people going straight to the mental health team. And I often see people and try and think about the really common things that would result in a change in behaviour, like changes in people's physical health, for example. So if there's something from a physical health perspective that is making someone feel rather unwell, it doesn't necessarily mean that they have a mental health condition, and that we kind of miss this vital step in healthcare in ensuring that people's general health needs are met before we entertain any other potential problems that person may have as well. Not discounting that mental health concerns are very important, but there's a whole other aspect in terms of a change in behaviour that I think we could address better in the healthcare community.
That's great. That's a good summary of everything. Thank you. So the next question is, could you tell us about a time when you identified a bias you or someone you were working with had, and how that bias was overcome or challenged?
Tricky questions, Ricky.
Yes.
I think I might give you an example of the most recent situation, or a case study, if we can talk about that, because I think it illustrates this situation well. So recently I was involved in looking after a young man who had had great difficulty in having blood tests. And he unfortunately had been subject to quite a bit of trauma in the hospital system with previous attempts to have a blood test. He had an intellectual disability and he had autism, and he had particular sensory adjustments that were required in order to make him feel comfortable. So what had happened in this situation is that he was actually looking progressively pale. So his family were quite concerned that he was unwell, and he wasn't able to do his daily activities with as much energy as he once had been able to do before, and he was starting to lose a little bit of weight. And what happened, Ricky, is the family were referred to me to see how we might be able to support a way of accessing healthcare. And then when we looked back, we actually realised that one of the last blood tests that he'd had some time ago showed that he perhaps had a health issue at the time.
Right. Yeah.
So it was picked up that he was what we would call anemic. So meaning his red blood cell count was actually quite low. And that had been some time ago. So we suspected that this had been going on for a long time. But what had happened in the conversation with his family is that no one had ever told the family that he had this condition. And it was decided, we could tell by the records, the medical records, or the documents, that the healthcare professionals didn't really feel that it was worth investigating at the time. And I think that was really troubling for the family, who were quite concerned over a number of years that his health, there was something wrong and that they didn't know what that was. And the way that we worked to overcome that was that we have developed a little team where we work with people who have difficulties or become distressed when it comes to having something like a blood test, which can be quite scary for a lot of people. And a lot of people have had bad experiences in the healthcare system. And what we really did to overcome that is to understand where the experience that person has had, the trauma at times that is brought about because of that, and then developing quite a person-centered approach to that. So the way we do that is we have a few people quite experienced. So we have an occupational therapist who's very good at working through the sensory needs of people and the adjustments that are required. And we have myself as a doctor, and sometimes people from the anaesthetic department in the hospital who can deliver medications that help people feel more relaxed. And as a team, we were able to build trust with this young man and deliver a way that he was actually able to have those sensory needs met, the trust in what we were doing, and some medicine just to help him get through the procedure. And we identified his health issue, and we were then able to go and get scans and work out that this was actually not a really serious health issue, but something that we could fix. And so that was really quite rewarding for us and for the family and for him. And that, I think, just goes to show that often we just need to change our approach and sometimes provide a bit of specialist care so that people can actually have the investigations that they need.
Absolutely, and I guess, it can be quite tricky to navigate those areas.
Very tricky. And sometimes I think as health professionals, we're only trained to get the information in a one-way approach. And some of our people, particularly people with an intellectual disability, actually need some adjustments in the approach and sometimes need a completely different way of working through to get to the bottom of what the problem is and to provide some care options. But they deserve these options just like other people do, and sometimes we just need to do it in a different way.
Yeah, and I guess the fact that you mentioned how the doctors that did the previous blood tests didn't really act upon what they were seeing just shows that there's still a long way to go and improvements.
Definitely.
Yeah.
Yeah, I agree with that, Ricky. And I think at times, because doctors really don't have any training in this area, they assume that because someone isn't able to sit still and have a blood test, that they don't want to have a blood test. And I think that's a really tricky problem that we have to address in the healthcare system, is that we need to provide other ways where people can still access basic healthcare, because without it, we do see some pretty poor health outcomes.
Absolutely. Can you share a story of how you have built trust with patients who have intellectual disability and have had negative experiences in the past? And how did you make sure their experience was positive?
It's a good question, Ricky. I think that the most important part of the trust process is thinking outside the square and being a little bit creative with how I might build trust with someone. And thinking about that last story, the young man that I was talking about before had unfortunately been traumatized with, I think it was 5 security guards holding him down for a blood test previously. So I have a lot of work to do when I have to overcome that level of trauma in building trust with people. So the first step for me is always really asking questions around past experiences, because that sometimes will tell me how hard I'm going to have to work, Ricky, to overcome some of those barriers, because often when examples like that are brought to my attention, I know that I'm going to have to work really, really hard. So being creative and understanding someone's past experiences are really important. I think a lot of health professionals work in a system, as we were talking about, that tends to only deliver healthcare in a stock standard one-way approach. And an example of that is often you'll see in a hospital environment, if someone is admitted into a ward because they're unwell, sometimes the doctors come around as a team, and there can be lots of them on the team, and sometimes they'll bring a computer, sometimes they'll have masks on, and it looks like a very clinical environment, and it can be quite overwhelming for people with intellectual disability. The doctors often talk in jargon, and they'll often talk at quite a fast pace. I'm very guilty of doing that sometimes, Ricky. And so what we do is really slow things down and think about where is the best place to even build this trust and rapport with someone? That might not necessarily be in a hospital environment. So sometimes I see people in a home environment. Sometimes I see people in the car park if they become very distressed coming into a hospital setting. Sometimes I might build trust by sitting on the floor with someone in a quiet space somewhere, so somewhere that's not so overwhelming for them, or pace with them. And then the way that I would build trust and bring in some of the assessment tools that I might use as a doctor is usually around role playing, because some of the ways that we gather information and the tools that we use can also be quite confronting. So I might first of all role play with someone like a caregiver, a family member, a friend, someone who is familiar to the person and that person trusts, as a way to introduce items that I might use, and then perhaps get to the point where we are able to engage in that process as well, but that the person has control over that. So it's really important for me to know where the person's comfort level is at, and that they have the choice to stop and to communicate with me that they're feeling overwhelmed in that process.
Absolutely. And I think in regards to when they're in hospital, when you mentioned all the doctors sort of looking over the patient, I guess that patient might feel as if it's, they sort of a number, not so much a individual.
Definitely. And particularly if the doctors then talk to someone else and forget to talk to the person who's having the care provided as well. And I think in part that's because doctors are very busy, and the system doesn't necessarily support the additional time that it takes for people with an intellectual disability to have the information delivered in a way that they understand and are involved in part of that decision-making process. So I think the system also needs to change.
Lots of change, and
being
able to have a sort of an open mind from a lot of people. Reflecting on experiences like the one you just shared, how was your approach to care evolved over time to reduce bias and provide more inclusive care for people with intellectual disability?
I think there's probably one key area that I've been working on for some years, Ricky, in terms of a more inclusive approach to care, and that stems back to that conversation we were having around people who find it difficult to have a blood test, as an example. And for me as a doctor, a blood test is actually a really basic health intervention, and I need that information to be able to diagnose health conditions, to be able to provide options in treatment, and then to monitor our ability to treat and manage those chronic health conditions or acute health conditions. So having a blood test is, to me, a really important part of my job, and I've always found it really challenging that the health system hasn't really designed pathways for particularly people with intellectual disability when they do find it difficult to have a blood test in the way that we currently operate, with lining up at a pathology centre and with lots of other people, and sometimes waiting really long time to have that in an environment that they're not comfortable with. So what I have been trialling in the last 12 months, Ricky, is what what if we actually designed an approach that met the needs of various different people and kind of delivered a system where they're at in terms of their healthcare? And that's a pathway that for some people will involve some relaxing medications, or sometimes we call that sedation. And for some people, it's just changing the approach. So it might be using some sensory tools like a weighted blanket, or turning down the lights, using relaxing music, using some fidgets. It's different for everyone. But what we've actually been testing is what we would call, and it's a bit of a mouthful, but a multi-tiered approach to minor procedures. And that's really where we have a few specialist clinicians or health professionals, each who has a different skill set. And we meet people and work with people over a series of appointments to determine for that individual what is the best approach, the least restrictive approach to health intervention, but that provides us with a path forward that's more inclusive of people and their needs, and actually gives them an option to access basic preventive health care that they haven't before. Simple stuff, Ricky, like the ability to have a vaccination.
Yeah, absolutely.
Many of my patients with an intellectual disability over the years have struggled to be vaccinated, and I'm just not sure that's good enough as a health system, as a world-class health system, that we need to provide a different path forward for all people.
And also, the idea of where, if you're not vaccinated, sometimes you can't participate in certain things.
Absolutely. It's like another barrier to exclude people from activities, isn't it?
That was great. And what should healthcare professionals do to challenge biases and improve care for people with intellectual disability?
Another big question, Ricky.
Yeah.
I actually think that a lot of healthcare professionals are not aware of their unconscious bias in this area. And in part, I don't think it's entirely their fault. I think that most of them have never had any education. And what I'm observing working in the hospital system is that the more people are educated in this area, the more doctors and health professionals are wanting to do better. So I think at the get-go we actually need better education and better understanding that we as health professionals often do come to these conversations with a level of bias, and that needs to be challenged. And I think at the moment that's often challenged by the caregivers and the support people when they present to access healthcare in different settings. Generally, caregivers are advocating on behalf of the person who's attending the appointment, and they're generally the people who are highlighting the bias that healthcare professionals have. I think the broader issue here around inclusive and accessible care, Ricky, is actually understanding that doctors sometimes need specialists to refer to when they're not entirely sure what to do. And I sometimes think that the bias in the way that people with intellectual disability access healthcare is in part because doctors don't know where to go for help when they don't know what to do. And as a general practitioner myself in a past life, I too would feel pretty uncomfortable if I was in a situation where there was no specialist to turn to for extra help. And I think that's something that we really need to develop, a bit like before we were talking about how accessing a blood test or an immunisation sometimes needs quite a specialist approach to make healthcare accessible. I think if we were to design those pathways and to provide those models of care, I think we would see a shift in the culture of healthcare professionals, knowing that they actually had an option to refer to when they were entirely sure what to do themselves.
Is there anything else you would say to healthcare professionals who want to make their practices more inclusive and accessible for people with intellectual disability?
I think there's a long way for us to go in terms of making healthcare across many settings more accessible and inclusive, but it has to be some of the most rewarding work as a health professional when we get it right. And I wish sometimes that other doctors could see the successes that we have and what that means to people who are accessing basic healthcare for the first time. I'm sure if other health professionals could see how rewarding it is, that they would be on board too.
Absolutely. So thank you for your time and sharing all that great information.
You're welcome, Ricky. I hope it was helpful.
Yeah, absolutely. Thank you for listening to part 1 of this episode on bias in healthcare. Please continue this episode by listening to part 2, where you will hear from Rachel Browne, who will share the story of her son, Finlay, who tragically passed away after not being able to get the care he needed in the health system. We hope you enjoyed the episode and learned more about delivering better healthcare for people with intellectual disability. To learn more about the work of the National Centre of Excellence in Intellectual Disability Health, or to get involved, visit our website nceidh.org.au.